What's up, everybody? My name is Daniel Unmanageable, and this is Hard Knox Talks. Tonight, we are going to do something a little bit different. A little while ago, I was cruising Facebook, and I came across this organization called Families for Addiction Recovery with like 10,000 followers. So almost immediately, my instincts kicked in, and suddenly I'm speaking with their founder, Angie Hamilton. And as we were talking, we had a great conversation. And I thought to myself, oh, we better get her on the same screen as Marie Agoritis from Mom Stop the Harm. And we are going to do that right after this.
I spent 23 years living in addiction. 16 of those years, I worked as a Red Seal tradesperson in Saskatchewan and Northern Alberta. During that time, I made many mistakes and took more than a few hard knocks. I went from tradesman to business owner to hiding from gang members and dumpster diving. But with that lived experience, I've decided to try and make a change. I've dedicated my life to raising awareness and promoting change in the fields of substance use and psychological health and safety. So join me and my guests as we take off the blinders around mental health in our communities and at work and shine a light on what's working and what's not working in the fields of mental health and occupational health and safety. I'm Daniel Unmanageable, and I'll be your host, and this is Hard Knox Talks.
Okay, so let's make sure everybody's unmuted. We're going to do this right the first time. Let's bring on, who do we got here? Here's Marie. Hello, Marie.
Hey, hey, hey.
How are you? How are you?
I'm well.
I'm well. And we have Angie. Hello, Angie. Okay. So.
Hi, Angie.
So, okay, let's, Angie, why don't you tell us a little bit about why you do what you do and a little bit about your organization?
Thanks. Families for Addiction and Recovery, or we just go by FAR, was founded by a group of parents who had kids who were struggling with addiction from a very early age, like their early teens. And we were founded because the needs of our families weren't being met, to summarize. So we're active in 3 areas. We provide peer support for other families, in particular parents who have children who are struggling, children of any age. And we do that through one-on-one phone support, through 4 group support meetings a month. And we also have a helpline from 1 to 3, Monday to Friday, Toronto time. And all of our volunteers have been trained in CRAFT, which is community reinforcement and family training, which in a nutshell is really about a non-confrontational approach and a compassionate approach to your loved one who's struggling with addiction.
Oh, we've already got someone chiming in. I don't know who's behind the brand there, but hello, thanks for the comment. Okay, Marie, why don't you tell us a little bit about how you got into this and about your organization?
In 2015, my son, well, first of all, 2011, my oldest boy got involved with opioids and ended up being very invested in that drug of choice. And we seriously thought we were going to lose him, but then a very unusual twist of tragic fate, my other son ended up dying of an overdose in January of 2015. It kind of blew me away, and I couldn't believe this had happened. So I started to get really vocal across wherever, anybody who'd listened to me, across Canada, local, whatever. There was a bunch of other women that were doing the same thing. And so we got together, 3 of them invited about a dozen of us out to BC in the fall of 2016. And we started up Mom Stop the Harm. And now we have several thousand members and several thousand allies. And what we do is like Angie said, peer support through online formats, and also there is face-to-face fellowship meetings across different cities across Canada for people who have lost a loved one to substance use, or to drug harms, really. I like the idea of your online call-in thing, Angie. That sounds really cool. Probably a ton of support. And so we're pretty heavy into the advocacy side of things through Moms Stop the Harm. And yeah, that's what we do.
Okay, so let's talk about safe supply. Ange, I understand you use a little bit different term than what we usually hear. You refer to it as safer supply. Why is that?
Well, I guess because, when somebody's struggling with addiction, there really isn't a safe supply. It's a safer supply. So we have lots of people, for example, dying from tobacco, dying from alcohol, even though it is a regulated supply. So it's safer, but depending on the person, it may not be safe for that person.
Mm-hmm. Marie, do you have anything to say to that?
Yeah, no, I think that's actually a really great point. Angie, is that we can't fool anybody to think that there is no negative effects potentially from substance use.
Yeah.
So no, yeah.
Yeah, just because it's regulated doesn't necessarily mean it's safe.
No, and I'd have to say too that it's certainly, if we have 3 things that we'd like to accomplish in our term as Moms Stop the Harm, safe supply would be one, for sure.
Yeah. So what about decriminalization? There is some interesting things coming to fruition here in Saskatchewan. Marie, do you want to talk a little bit about that?
Yeah, it's kind of been what's keeping me busy lately. So different cities, of course, BC right now, Vancouver is looking at a model of adopting a model of decriminalization for personal use of drugs. And then some of the problem that they're having is in trying to set that standard. What does personal use of drugs look like? Is it for one person, it can be, a point of heroin, and for another, it can be 10 points of heroin that's needed in a day. So I know what they did in places like Portugal was they would give you a, let's say, a 10-day supply of your drugs. So there's a whole lot of things to work out, but they are looking at it. And of course, what we see as an option because of right now, the criminalization of people with their personal drugs isn't working. There's just this turnaround in the court systems. There isn't any more in the budgets. They're focusing. We've got our police officers focusing on attacking small drug operations that really, everything from the young guy in the trades who's using drugs on the weekend is subject to criminal charges and criminal convictions for personal drug use. And and the idea, I think, ultimately is that from a criminal justice place, the idea was that if we impose enough penalties, it'll turn the behavior around. Well, when you talk about substance use, it doesn't work that way. And also, I always akin it to alcohol, that we have a safe and legal supply of alcohol for personal use. Mm-hmm. And with that, what we've done is given robust campaigns that provide awareness to drinking and driving and all the negative outcomes of alcohol. But if we'd made the alcohol illegal, like we had some years ago, we would no longer be focusing on the areas of awareness that kept the community safe, because you're not going to remove alcohol use. And that's what we found during Prohibition. So really, it's sort of it's a model that works really well. And it's not about giving somebody a break so much from criminal activity. Criminal activity is criminal activity. This is an activity for personal use that really isn't doing any justice to anyone. The system itself and the Canadian Association of Chiefs of Police support it. They've done a whole study on it and they support it.
You mentioned Portugal, and I've been talking with a guy overseas, and he has a contact in Portugal, I believe a social worker. And I'm going to be working towards getting that person on this show to talk about what they're doing in Portugal, because from what I hear, it's working. But, I have to say, when somebody says they give them a 10-day supply, now being with, my years and years of lived experience, a 10-day supply can turn into a 1-day supply real quick.
Oh, for sure.
So, I kind of wonder how that would look like, would would it best be served as a daily thing? Like people go and get their methadone drink every day, because, I don't know, like you give me a bottle of pills and I'm not going to be able okay, I'm going to do 3 today and 3 tomorrow. It's not, for me, that's not how it worked. So, but anyways, and what's happening over in Ontario with decrim?
Well, we just had a meeting at the Toronto Board of Health, and they asked for the 4th time since 2018 for the federal government to decriminalize drugs. So we've been asking for a long time, but it's important to note that the Toronto Board of Health is not the same thing as the City of Toronto. So we were hoping that this time the Toronto Board of Health would ask the city to ask the feds to decriminalize nationally, and only, sort of do it. If they really can't do that, then do it on a city-by-city basis, but to make it clear that the preference is that it's not on a city-by-city basis. And in fact, that's what I gave a deputation on, and it came close, but they didn't vote that in, so they didn't make that amendment. So it just says that right now, that again, the Toronto Board of Health wants the federal government to decriminalize drugs, and they're going to set aside or establish a working group. And I think this is really to buy the Board of Health and Toronto Public Health some time to get a group of people together to make the arguments and make sure if they go to the city and ask for them to ask the feds to decriminalize either nationally or on a city-by-city basis, that it will meet with a majority of votes in favor from the councillors. And I think it must be that they didn't think that they could get that now. So it's a little disappointing, honestly. And I do want to get in one thing, which is, to do this, like, criminal laws are federal, and if you commit a crime, you're labeled as a criminal, and it has lifelong effects. I don't think criminal law is something where you should be doing a pilot project somewhere, so that if my kid standing here has this much of this drug, they're going to be criminalized. But if they were standing over there in Canada, they wouldn't be criminalized. Like, that's illogical. That's inequitable. So what are we doing? Are we just, having the big cities where, the kids aren't going to be criminalized, but the rural communities, they are going to be criminalized? Like, I really object to that approach.
If I could add something too, like recently in this last week, I met with our police commission. I had a meeting with the police commission to ask them to support a decriminalized model. And one of the things that they said to me was, okay, well, what exactly do you want from us? And I said, what I want is I'd like to see cities across Canada support the model in theory and look at the federal agency to move the regulations and the laws to help change it so that this can become an opportunity across the country. Now, of course, we're dealing with politics within the province, and that too is going to have, because you may see the feds say, okay, you can do this, but I don't know if that means yes, it's done in its entirety if they choose to take it. And I also know too that even when there's a bill right now in the Senate in Ottawa, bill, I think it's S229, I think. And that bill went through a second reading in the Senate this last week. And it's still looking positive. The Senate's liking it. So we may see it in the House. I don't know if it'll get through there. But one of the big parts of that bill was looking at, we can't just decriminalize with some a robust model of healthcare that comes with it. So you're looking at changes to healthcare too. So yeah, that's the other thing that I was going to say. So that is the big thing for me right now. And I should say that when we did go to the police commission in Saskatoon this week, the chief of police, the mayor of the city, and most of the meeting seemed to really say, yeah, we are in favor of it. We could use a shift of the resources that we've got doing something that's not working right now and only serving to marginalize and destroy the lives of people that have already dealt with it. So yeah, I think we could potentially see it in this next year, maybe 2.
Yeah. Well, we've got Mayor Clark. We've got Mayor Clark coming on next week.
Yeah.
So we're going to definitely be talking a lot about that. So
What
Angie,
do
you
you
were
think,
going
Angie?
Well, it just they can't do it without the Fed. So I think
Yeah.
maybe after the next election,
Yeah.
hopefully.
Yeah.
But yeah, it's
Checking up.
it's shocking to me after the Canadian Association of Chiefs of Police said we need to do this. I just thought, okay, done deal. And then even recently, the Canadian Society for Addiction Medicine. I mean, when you got the addiction medicine doctors coming out and saying we need to do this, then to me, it's stunning that there's such resistance. And actually, we have an Angus Reid poll that shows the majority of Canadians support it. So really, it's the politicians that are really,
Yeah.
and they're afraid of losing votes.
Yeah,
And
100%. 100%. It's so political, all of
So,
it.
Marie, why are we seeing municipalities asking for exemptions, like individually, when criminal law is a federal responsibility?
Well, I think because they're getting anxious because so many people are dying.
Mhm.
You know, I think certainly everybody'd like to wait for the feds to catch up.
Yeah.
But at the same time, when you're dealing with death after death and the criminalization and the way that it just absolutely destroys lives. Like, as I said, you can be a completely effective guy and you get caught with a weekend supply of whatever your drug of choice is, then that could be a small amount, but that leads to criminal charges. Now, all of a sudden, you can't be bonded. You can get an apartment sometimes, but you're having trouble getting all sorts of things because you've got this charge against you. So it destroys lives. And I think that what they're trying to see is opportunity, move it aside, and also a shift in the spending. A shift in the spending, even if it was just from a police agency. Right now, our police officers in Saskatoon are going out and happen to act like social workers at night.
Yeah.
And we would like to see a better care model from within that provides them the support and the people that they're working with on the streets, the support, and even just the guy, as I say, who's using on the weekend. That's one thing I'm always careful to say is that we make this assumption that people who use drugs are always this really marginalized community, and that's not the truth.
No.
It's lots of people use drugs.
Yeah. So I guess the question was more about like, why are we having to go municipality by municipality by municipality and slowly get each individual one to buy in? Because from what I understand, Moms Stop the Harm is doing something like that. And how many municipalities do you have on board now?
What we had going on was we were going municipality to municipality to get them to support calling the overdose crisis an overdose crisis in Canada.
Oh, okay.
We want them to support that, because then what that does is if they actually name it as a national crisis or whatever it is, then we get then there's access to extra funding that can come of that to battle it.
Okay.
Yeah. And so that's what we've been doing. And I can't remember how many exactly, but we've got a lot of communities. So right now, this idea of decrim, we're just walking into it when the opportunity hits. It happened to hit the agenda in Saskatoon in our commission's meeting. And I found out about it and thought this is a great time to talk. And then what we did is engaged academics in that dialogue and police officers in that dialogue with some meetings. And then we've got academics and some researchers right now working on some of the statistics that come out with decriminalization as it with respect to community safety and sort of like your return on investment for having people criminalized for personal amounts of drugs. So we're going to be supplying that so that we can get it back to the community and an awareness to the community through our civic leaders.
So we've got over 50 municipalities. So we've got another comment coming in here from Nicole. Thanks for the comment, Nicole. Thank you for sharing, and thank you for everything that you do, ladies. It's excellent. Thanks for the comment. Ange, what would you like to say about this?
Well, I guess maybe the only thing I'd add, because I agree with everything that Marie just said, is, when I try to explain it to people who don't understand about decriminalization, I like to draw an analogy. And the main purpose of criminal law is to protect people from other people, not to protect them from themselves. That's That's the job of our health laws and families and that kind of thing. So prior to 1972 in Canada, it was illegal to attempt suicide because it's bad for you. You know, it's like the ultimate act of self-harm, right? Mm-hmm. And we look at those laws today and we think, what were we thinking? Like, how would you ever help someone, you know, who is clearly mentally distraught, maybe, you know, severe depression? How are you going to help that by criminalizing them? And, you know, it's long overdue that we recognize the same thing with people with substance use disorder. So there are people who, if we regulated the product, would not, you know, in fact, majority, you know, if we regulated products, would not have problematic use. So we should just be letting them go. We don't need to harm them with a criminal record. And those who have problematic use, they do not need, you know, this, if your 14-year-old turns out has a problem, you know, you're not going to think the solution is for them to get a criminal record and go to jail. You're going to think that they need help and they need treatment, right? So it's this distinction between self-harm and harm to others. So there's nothing inherently criminal in consuming a substance. It's taking something in to alter your mind, which is something we would do with alcohol that's legal, cannabis that's legal, cigarettes that's legal. I mean, a lot of things we take to alter our minds and their, you know, moods, and those aren't criminal activities. And there really is nothing different, inherently different, in using this substance or that substance to do it. And we already have the laws, you know, to protect people if under the influence you drive impaired or you hit someone or whatever you do. Those laws already exist, and we are not talking about decriminalizing those things. So it's just not an inherently criminal activity. It never should have been criminalized in the first place.
We've got a question coming in from Brenda. What is happening police-wise in Toronto? Are they on board?
So we are in the middle of getting a new chief of police. So nothing's going to happen right now, but in the Ontario Chiefs of Police Association, I understand, is in favor. So again, it's the police aren't the problem. I'm anxious to get a new chief of police and permanent. We have a temporary, but a new permanent one, and then we could go talk to them about that. But yeah, it's not going to happen while we've got a temporary person in there.
Okay. So what's going on with supervised consumption in Ontario right now?
Well, not enough of it. Not enough of everything. I mean, when this government came in, one of the first things they did is they got rid of the opioid task force. I mean, how do you do that?
What is an opioid task force exactly?
It's when you get all the experts together and go, gee, we've got an opioid poisoning crisis here. What are we going to do? And the experts tell the government, well, it's like the science table for COVID. It's like we had a science table for opioids, and just as things were, you know, continuing to get worse, we said, oh no, we don't need to know what the experts think we should do. So they got rid of it.
What was the reasoning behind that?
Well, I can't speak for our government. I see none. You know, it's even worse because it's not like they've got treatment on demand. We don't have treatment on demand. If you need residential treatment, you're going to wait. If you need detox, you're going to wait. And God love you, if you've detoxed, you're going to wait between detox and residential treatment. And if you could wait, like the 4 to 6 weeks you have to wait,
white knuckle.
You wouldn't need residential treatment, right? So,
Yeah.
So you know, so they got rid of the task force. They put some kind of artificial cap at 21 on the number of supervised consumption sites. I mean, this makes no sense. It's like, you know, it's like saying, well, we're going to have 72 hospitals. Well, do you think maybe it should depend on need?
The need?
Maybe? You know, like No, so there's not enough harm reduction services. I mean, there is some good news. The feds have funded some new safer supply, and the Works in Toronto is getting, I think, IOT, but it's not heroin. It's liquid hydromorphone, I believe. So, we do have safer supply programs, but we don't have enough of them, and we don't have all the options that we need, with respect to a safer supply.
Got Angela chiming in here. She's saying, thanks for the comment, Angela, saying the same things happened in Alberta. The governments have set us back. I would have to agree, Angela. Marie, what do things look like in Saskatchewan on the supervised consumption front?
When I listen to Angie talk, it's like she may as well move to Saskatchewan.
Yeah, I was thinking that
same thing happening. Yeah. It's political will. It comes down to it 99% of the time. And even within that, and with that will, they could provide some awareness. They could come out to the general public and provide campaigns to say, this is why we need to do these things. They could, if your collateral isn't life, which, of course, for those of us that have dealt with kids like this, we understand it's about life. But if your collateral is what's it costing our community, what's it doing to public safety, there's proof out there, and all they would have to do is deliver it to the community to be able to get the support that they need. And even I talked to one of our ministers the other week, and they were talking about, what the voting public wants. And I said, you already have 80% of the popular vote. If you threw $1.50 over to prairie harm reduction in Saskatoon, what, you might lose 2%? Like, if that, you have to get realistic about this. So the will is just so far behind. Prairie harm reduction in Saskatoon, it has an excellence run by a guy named Jason Mercury, who you've had on the show here. Excellent guy. Super effective, really well spoken, working his butt off, and he's running a safe consumption site for about 6 hours a day right now, and a great organization in the back end of that place that provides housing and provides wound care and provides all sorts of things to help people.
All sorts of open doors. All sorts.
Absolutely. And then there was a provincial the province got a temporary exemption for a bunch of different safe supply or not safe supply, safe consumption sites in different hotels during COVID that were housing persons that were drug users when they were, needed to isolate or they had COVID. And so they had some temporary exemptions. And so an agency in Regina, a guy in Regina, got together and used one of those to be able to open up a safe consumption site. But we're hearing they're going to actually try to force him to shut down in the fall. That's what we're hearing. So it's tough slugging here. And really cool thing that happened in Saskatoon is all of a sudden, when he didn't get his funding in this last budget, a ton of community members got together, business owners, and started doing fundraisers to provide him with some cash. And
how much did he end up with there?
I can't remember. It was a good amount. It was thousands. And that helped a ton for him. And what the great thing was is that it sent a message that the business community does in fact support the initiatives like this. And I know that our youth does. I think it's a matter of time. But in the meantime, how many people are going to have to die? How many elected officials are going to have to age out of politics before we get people who really look at the evidence to make stuff like this work?
Mm-hmm. So, okay, let's move on here. Marie, what are your thoughts on involuntary treatment?
Involuntary treatment, we're not huge fans of it. And one of the main reasons is because right now, voluntary treatment is so inept. It's horrible. We don't have the right healthcare systems involved, the right amount of time. And just as Angie spoke, you can't get into detox in a timely way. There's wait times between. Anything that has to do with voluntary treatment is so severely undermanaged from a political place, not from like the people who work within these organizations. I always want to say their hearts are in the right place. They're doing everything that they can, but the government that's running them, we're just not getting what we need from voluntary treatment. So my fear, and I know the fear of many, is if you create this involuntary environment, how do we guarantee a system of care that's not going to further marginalize or further hurt people? That because most youth that are involved in drugs to a level that becomes a very harmful level, it's as a result of trauma. So what is in place to ensure that if they are in, that it won't feel like they're further traumatized? The other thing that coerced care too, the fear is that, let's say kids are all sitting around and they're using drugs and one of them overdoses. And one of the kids says, I don't want to, if I get caught and we're going to have to be institutionalized for a period of time because I'm using drugs and I'm underage and you're using drugs and all this happens. And what if they potentially leave them to die? Because before the Good Samaritan Overdose Act came into place, my son died as a result of being left alone in our home because the kid he was with was too afraid to call 911, and my son died. So that is the other part of the fear of coerced care. We need to beef up our youth career or our youth programs that are culturally appropriate, youth appropriate. We have to do something at least. We're not doing enough on the other side of it, let alone to go into a coerced care model. And we do have a 10-day detox, a coerced detox in Saskatchewan that you can, as a parent, get hold of. And I've seen parents where some parents who have the funds, it can get them into a place where they can apply, get their children into a private place right from detox, talk to the child, maybe they're interested. But what typically happens is people don't have that kind of money, and the person gets out of detox, they're raging mad, there's nowhere for them to go, and they're coming home to their families. So it's just not ready. And I also worry about the traumatization of people who are already feeling marginalized as a result of whatever's happened to them as kids. So
do you think that with the appropriate aftercare programming in place, that there could be some success in you call it coerced care? Is that
I think any evidence-based efforts for recovery is going to improve where we're at right now. We don't exercise models like right now. We still have 28 30-day treatment programs in Saskatchewan. That's all we have for provincially funded programs. We don't have aftercare. We're even down to psychiatric care in Saskatchewan. We have very few psychiatrists. When it comes to psychological care within our provincially funded system, we have social workers with 250 cases. Administratively, how are you even going to do that? So it's a bit of a mess, and it's no wonder our kids are ending up where they're getting, or ending up where they are right now. So yeah.
So you're suggesting a big part of it is the system is simply not ready to handle something like that.
I think it takes a lot. It takes a lot to see what it works. I think that if we had a robust system of care for the youth, we wouldn't have to look at coerced care.
Mm-hmm. Okay. Ange, what have you got to say?
Well, I guess a lot. I agree with a lot of what Marie just said. We don't have enough. Really, what we're talking about is residential treatment for youth on a voluntary basis. In Ontario, we have a really good program at Pine River Institute, but the wait when I started this work in 2015 was 14 months, and today it's 14 months, and there were 200 kids on the wait list back then, and there's over 200 kids on the wait list now. So this is a big problem. But a bit of history, if I may, on the history of involuntary treatment in Ontario, because I think it's important that people realize this isn't just me, and this isn't just the families I represent that are looking for this. In Ontario in 2009, the government, because they realized treatment of mental health and addiction was so ineffective, they traveled the province and they interviewed, people with lived experience and their family caregivers and the service providers. And in 2010, they came out with a report with 22 recommendations. And one of the recommendations was we have to look at involuntary treatment. And I have to say this is with respect to adults. And some of the specific problems, which I do just want to get into for 1 minute, in Ontario, there's a system which allows you to detain somebody if they're a harm to themselves or others. But that doesn't necessarily mean that you can treat them because they didn't tie it together. And it's tied together in BC. So in BC, if you're sick enough that they can deprive you of your liberty and detain you because you're deemed to be a harm to yourself or others, it flows from that you're sick enough for them to treat you against your will. And the advocates in BC don't like that, and they want the Ontario model. And just a word of warning there. So in Ontario, this recommendation was like, you've got to fix, look at involuntary treatment in general, but fix this particular problem. So to give you an example, there's this paper. It's a great paper. It is treatment delayed, liberty denied. So as an example, there's this gentleman, he referred to himself as Professor Starson. So that's how he's known, but he wasn't a professor, and Starson wasn't his name. But he was deemed to be a harm to himself. So they couldn't let him go. But he was deemed to have capacity to make treatment decisions, and he refused treatment, so they couldn't treat him. So he was detained, basically locked up without treatment for 7 years. And by the way, the longest person at that time who had been in that situation had been locked up for 25 years. So these are people they haven't committed crimes. They're locked up for 25 years because they have capacity to refuse treatment. They refuse. So it got so bad with Professor Starson that they were afraid he was going to die because he stopped eating because he thought every time he ate, his child was being tortured. He didn't have any children. And he was going to die. So they decided there was some change of circumstance. They treated him with medication. He improved and out he went, right? So this was with respect to adults. And historically, honestly, addiction is a pediatric illness. And by that, I mean, if you start use before the age of 15, you're 6 times as likely to develop a substance use disorder than if you start at age 21. And 90% of the time, it starts to develop during adolescence. So this is disproportionately affecting, young people. And when they're in this at a very young age, it's the rule that they have other mental health conditions. But historically, we've only ever applied our Mental Health Act when somebody has been a harm to themselves. They might have substance use, but it's usually because of other things. And the act requires that people then get locked up in a psych ward. And we did a presentation on the legal issues to the addiction medicine docs in September at a Medify conference. And we said, so when people show up, even kids, and they've overdosed and you just let them go, to us, they're a harm to themselves, because if they're struggling with addiction, they can't stop using. You haven't given them anything. They don't have a safer supply. And if they want, you haven't even talked to them about treatment out, they go, how are they not a harm to themselves? And they basically, and it wasn't like a big, but the result of it was, well, actually, we do think they're a harm to themselves. But a locked psych ward isn't the right place. And I agree, a locked psych ward isn't the right place. And what is the right place is like what they have in the States for kids, is make it as normal as possible, which is something like a therapeutic boarding school if it's not safe for them to try to recover in their community. And for many of our kids, it isn't safe. So the reason we want involuntary treatment is because our kids at a young age, they didn't have money to fund their addiction. So how are they getting that? They're all involved, frankly, in activities that are not harm to self, but harm to others. And we don't want that. And we want them to get better. So the opposite of involuntary treatment is not voluntary treatment. If they go, that would be great. Everybody agrees that's better. Of course, that's better. What if they don't go? The the opposite of involuntary treatment is untreated addiction and mental illness. The kids are sexually exploited. They're lured into the drug trade and they're criminalized. They become homeless, which is an adverse childhood experience. And some of them overdose and die, and some of them overdose and have heart attacks, but they don't die, or they have brain damage and they don't die. It's all bad stuff. So we agree we need to build the system. That said, it isn't helpful if people go around and say coerced treatment is always wrong and bad and violates people's rights. If somebody's right to refuse treatment conflicts with their right to life and security of the person, we better prioritize life and security in person than, over their right to refuse treatment. So in a nutshell, that's kind of it.
So do you feel like the decision to put a youth into coerced care should be a justice decision or a family decision?
So I think this needs to, it's complex. So yes, families should be involved. First, there's a serious issue of capacity here that isn't being addressed. Capacity to make treatment decisions. I mean, their executive functioning isn't fully developed because they're young, if they're youth. Their executive functioning is being affected by their substance use. It's often affected by their concurrent disorders. So, if they don't have capacity to make treatment decisions, the parent gets to make the decision in Ontario. We have substitute decision makers. It's the parent. So families definitely should be involved. But, yes, it's possible that a family, especially if they just think all substance use is terrible and we have to have safety measures to make sure that, a kid doesn't touch a joint and the parent wants to, ship them out somewhere. So there needs to be support by a medical professional that agrees this is this kid does have this condition and that this would be in their best interest. So, and the child's voice is important. They can say, and in Ontario, they do have, the child's voice is important and, they do have a say. So all of that is important. It's important to have the legal safety measures in place. So it involves everything. But what I don't want is like drug court. Like, it sends a message to the kid that you're bad and you need punishment, even if you're diverting them and sending them to treatment. Like, why do we have to do that? Why, if we know that they're engaged in criminal activity because they're struggling with substance use disorder and concurrent conditions, why do we have to, involve criminal justice system to get them the help that they need? I don't agree with that. I think we should bypass that and just go straight to, the system of looking at whether they have a serious problem and whether this is in their best interest. And by the way, the UN Convention on the Rights of the Child, it has a provision that says we have a duty to protect kids from illegal substances. They have a right to health care, and all of our laws have to be drafted in the best interest of the child. And that hasn't been incorporated to our health laws. Really at all. It is incorporated in our child welfare laws, and it's incorporated in our criminal justice system and juvenile detention, but it isn't incorporated into our medical system. And we're never going to solve this just by saying cops have to step back. It isn't just cops have to step back. The medical profession is going to have to step forward. And we're going to have to look at laws that say, you know what? If they're going to go to jail because they're harming others, and it's because they have substance use disorder or other mental health conditions, it's better for them to get treatment. And our laws don't do that right now.
Yeah. So this isn't a matter of they're out using and the cops bust in the door and you're going to treatment. This is a process that involves both the justice system and the family system. Yeah. In your opinion, that's what that should look like?
Mostly the medical system.
Yeah.
Okay. These are addiction is a potentially terminal illness. right?
Absolutely. Yeah.
And it's a lack of capacity, either total or significant, when it's at the severe end with respect to your use and what you have to do to get your substance of choice, you know? And so I do get upset when people always talk about, you know, autonomy of people who use drugs. That's great if they don't have a problem. And agency in recovery is important. They get to pick their pathway, but don't tell me people in active addiction have full autonomy and they're completely in control of their drug use, because the definition of the illness is they aren't in control of their drug use and what they have to do to get their drugs. And alcohol, always in this, alcohol is a drug. Right.
Yeah.
So we have people dying from alcohol and more than are dying from illegal substances. People aren't even talking about it. Right.
That's right.
And I hear doctors talk about, some of them are pre-contemplative. They don't think they've got a problem and they're dying. Now, that raises serious issues of capacity to me. Like, I really think that the medical profession should be stepping in that situation and saying, this person's a harm to themselves, and we need somewhere to send them and keep them there long enough so that they have a chance, not 7 days, for God's sakes, not even 28 days, but a longer period of time where they can get stable and absolutely use anti-craving medications and all of the medications used to treat substance use disorder, assess and treat co-occurring conditions, give them the coping skills that they need, and they need wraparound services, you know, when it's safe for them to be in the community. It's not always safe for people to be in the community when they're starting off in recovery.
Yeah. Marie?
You know, the only thing I can think of right now that would be a really great place to ask that question is people in your situation, which I know that you can't at this point, Daniel, answer a question like that because that's not your role here. But someone in recovery who's gone through it as a youth, and so what would it have done to help them, or what about some of their friends that have been on it? I think that that's a voice that needs to be heard. Not saying that they would go one way or the other, but I really think that we need to ask that question of the people who've lived it. You know, Angie and I have lived it as parents. I don't know entirely her history, but I think that we do need to start asking the people who have lived it as youth and what they think too.
You know, I can speak to that because I do know the mindset. I started using when I was 13 years old. And I can tell you that, you know, there would be a real issue if one of my friends was overdosing, and I was afraid that if I was there when the cops showed up, that I would be detained. You know, that would be a fear to me, and you know, my parents are going to be pissed and all this shit. But I'm sitting here and I'm thinking and I'm listening to Ange talk, and I'm wondering if there is a possibility that there could be a way to make that transition easy enough so that fear can be somehow mitigated, because I do see a use for I mean, like when we're crazy. We can't make good decisions. That's not, you know. So how do we accommodate someone that doesn't know or doesn't think that they need accommodation? You know, how can we impose that on them? I mean, I think in certain situations that there might be something there, you know, that we might save some lives by doing things to people that they don't like, putting them in places that they don't want to be, you know?
Well, and if it's done right.
Well, and that's the thing, though. How do you do it?
They won't want to be there maybe for the first week or two. And if it's done right, they're going to want to stay, is what I would say. And I know that I have had conversations with Von Dowey at Pine River Institute, and they always take a couple kids who have been court mandated there through the criminal justice system. And after 6 months, they go to court. The average length of stay at Pine River, I believe, is 14 months. And 95% of their kids go on to post-secondary education. So he said that the kids who are court mandated after, and I'm generalizing, and there's not a lot of them, but in general, when the 6 months is up and they go back to court and they say, okay, you complied, away you go, you can go, or what, and they choose to stay. Like, and it's not a locked psych ward, it's in a nice location with other kids, and they're going to school, and it's a therapeutic community. And that's what you want. You want your kid to be getting the help that they need and still getting on with their education, and not homeless, being sexually exploited, and taking substances that could kill them, that they've lost control over. Like, the alternatives to this are bad.
I can't help, I'm sitting here and I'm flip-flopping around, like, I can see positives in what both of you are saying, but something I can't get past is the spike that would drive between a family and a young one. If there was that risk, like the youth doesn't want this accommodation, doesn't think they need this accommodation, so they're going to try to get around it. Or I can see that being a problem. But also, like you said, and being out in the street and being exploited and doing terrible things is also a problem. So there's no.
Yeah, I worry too that is it an entirely lockdown situation? Is it, then if a kid gets out and runs to the street and doesn't want to come back because they don't want to be there, and then they're hiding in places that you've already just tried to rescue them from. It's such a complicated issue. And understandably, it's terrifying when your child is using drugs. Terrifying when doesn't matter how old they are. My son started at 16. The one who's in recovery now. And I know that he would have done everything he could to bolt from something like that. And then I really would have lost him. So it's a really, really complicated thing. And as I say, we really do need to listen to the voices of lived experience from a user perspective, who's gone through it as a youth system, and see what would work. But
as a person with lived experience, I can also say that there was a good stretch of time there where I wasn't competent to make that decision to go into treatment, and I could have easily died. And I can't say for sure if I'd been locked up with the appropriate accommodations, which we both know don't exist right now. But if they did, if I was locked up and I was given top shelf treatment with top shelf professionals and peer support and all that shit for 6 months, maybe that would have done it.
And I don't know I don't think there's a government out there that would put it together, to be honest.
No, and that's fair enough.
You can't even get them to do bottom shelf right.
No, and that's fair enough. But I'm just saying, if hypothetically these services were in existence, maybe they would work. We've got Brenda chiming in here saying, we can't even get suicidal youth people kept in psych wards if they don't want to stay. Yes, that is true. I have known a lot of people that have left the Bay, and I've seen them, and I'd be like, well, how did they let you out? So what else do we got here? How are we going to make the move to therapeutic treatment centers? North Battleford Provincial Hospital? Did I read that right?
Yeah, where are we going to send them, I think, is what Brenda's saying. Yeah. We're going to send them to the North Battleford Provincial Hospital. And is that a therapeutic treatment center, really?
It doesn't have to be hospital settings. And what I would say is, like, they've been doing this for years in the States, and lots of places do it wrong and some places do it right. And I think we can learn a lot from that. I think everybody would agree that the voice of youth, particularly in co-designing a system of what it would look like, is important. I can say, my son, the last time he was in treatment in the States, he was there voluntarily. We were paying thousands of dollars a month for him to be there. And right next to him was someone court mandated there. There were no locks on the doors. It was a beautiful facility. Honestly, if people know if they run, they're going to be brought back. It's pretty rare for them to run. And if it's run properly, it's therapeutic. People keep assuming, and I understand why, because Honestly, we had someone in 2018, one of our members' kids was at a treatment center voluntarily, and they didn't like something he did, and they shaved his head. He was 26 years old. So yeah,
Who
that's
did? Who shaved their head?
the center.
The center shaved his head.
Yeah. So what I'm saying is, the government doesn't regulate these places, even the voluntary ones. How much you spend to go is no guarantee you're getting evidence-based treatment.
Yeah.
But this question is not, should we have involuntary treatment or shouldn't we? That's not the right. That question means you're assuming 100% of people have capacity to make treatment decisions 100% of the time, regardless of age, co-occurring conditions, drugs being used, circumstances, and that's ideology. And you're making the assumption that people who are a harm to themselves or others all want treatment, and they don't. So we need involuntary treatment. It's as part of the continuum of care. This is a small percentage of people who need this, but it needs to be there. The question is when and what should it look like? Mm-hmm. Those are the questions.
Well,
and I get upset when people say no involuntary treatment ever. They usually immediately go to it doesn't work, which drives me crazy. Because there's a great lack of evidence, because show me all these people this is happening to. Like, very few people are getting evidence-based treatment, voluntary, involuntary. They're just not.
So what's evidence-based treatment? Just so that everybody knows.
Okay, so for sure, for opioid use disorder, it would be the medications used to treat that. So Suboxone, methadone, Cadian, that kind of thing. And for alcohol use disorder, there's also medications to deal with cravings. But they would get assessed for co-occurring conditions and treatment for that at the same time. Don't do this. The silos drive me crazy between mental health and addiction. They still exist. So it's like, oh, we can't treat your mental health till you deal with the addiction. Or we can't treat with your addiction until you've solved your mental. Oh, come on, guys. For 20 years we've known that they have to be treated at the same time. Addiction
is mental health. It's the same thing. I get that. Drives me nuts too. I mean, even in Saskatchewan here, we've got mental health and addiction services. Like it's stigmatic. It's like there's a difference. And usually if you say addict, then well, that's a stigmatizing word, and you are judged, based on that. So yeah, I hear that.
And from our end, it would be the fear would be that the lack of preparation, the lack of proper services and proper care models put together to make this be effective for the kids.
Yeah.
Kids or even, anybody who isn't really in their right state of mind, even when you've got a 25-year-old that's a harm to themselves and others. We just simply don't have a healthcare system right now that could make that work. Yeah. And I'm afraid, like even looking at some of the Indigenous communities where, they've got some historical issues with removal from families and culture, the whole idea of what's culturally appropriate for them, and having, what it looked like where they're taking away, is it the family, as you said, is it the justice system, which maybe it's an alternative to jail for some. Mm-hmm. And I could see some kids going, yeah, okay, well, I'd rather go there than to a youth detention center for 10 months.
And we do have something like that. There's been lots of people that say you can go to treatment or you can go to jail. What is it?
No, we don't have that in Saskatchewan. There's drug court in Regina. Yeah, well, there might be some.
I think there's or perhaps maybe I'm thinking like a condition of parole or something like that, because when I was in treatment, like there was the guy in there that said, yeah, I'm here because I want to stay out of jail, and it was because of a situation.
It can be a condition, but at the same time, if you're sitting there at a sentencing and they say, okay, well, we're going to let you go, but you've got to get into treatment. Well, 3 months later, he's supposed to be in a treatment bed. He's not, and he's relapsed on the street, and now has broken all his conditions. And I think we're so far from doing it effectively right now, and the harms that can come to the kids. So it's just a real tough subject. It's a real tough one.
So you're suggesting that if this were to work, that it would likely be a very small part of a much bigger plan that would have to be put in place. So the
Sure, yeah.
involuntary treatment would be just a small part of this spectrum, the aftercare and the support.
And also being very careful to ensure that it didn't become the rule of order for a child that's using substances at any level, because that's when you're going to have huge problems. You know, it's somebody who, you know, we can't suggest that people, as you said, Angie, with concurring disorders, when you've got real mental health disorders and, you know, efforts to appease your mind with substances, and it's just made it worse and worse, and they are a danger to themselves and others. That's when the serious considerations need to be done. It's a mental health issue. But just what would the standard be anyhow? But no, that's
the only thing I'd add is we need to work on both these things at the same time. Like, don't wait 10 years, you know, until we've got all the voluntary stuff in place to start working on what an involuntary treatment service would look like, because we've been waiting in Ontario for 11 years so far for something that everybody agrees is violating rights and is a horrible system. And the government, frankly, is too afraid to act, because we went to see them in 2016, because it's divisive. And frankly, they are afraid. They're afraid of looking like they're infringing on someone's rights. And to me, this is done right. This protects people's right to life and security of the person. So we need to work on creating a great voluntary system and make sure that the people who need involuntary treatment, once we've got the voluntary treatment system in place, can be put right beside the people who are there voluntarily. That's what it looks like to me.
Okay. So this is on a spectrum. Like I think what Marie is concerned about is that this is just a box checking procedure, that either involuntary, or, you know, if you get caught and you're young or you need it, then there's not one set bar. This is a spectrum of possibilities depending on a ton of different variables. And to get something like that in place, I mean, holy cow! Like how would you make that decision?
And Daniel, we actually kind of do that right now with just even the basic psychiatric care within our existing healthcare systems, even in Saskatchewan. Somebody comes in and they are, as you know, you've seen it, where let's say they're in psychosis, or they've got really poorly treated mental health and they've got an addiction on board on top of it. And right now, even when it is recommended that they might spend a few days in our local center for persons suffering in that way, they're out within 2 or 3 days. So even there, it's not being handled in any effective way. It's almost as though you're discounted for decent mental health care because you have a drug on board. Suddenly, the drug addiction trumps the mental health. And so, you know what? Go get yourself some treatment and get off the drugs, and then we'll deal with the mental health. And it's just there's so much broken. So much broken. And the top of that chain is, again, political will. The very top of that whole chain is the fear of upsetting the base and not listening to the people dealing with it every day and doing what the experts are telling us to do. So we got a lot of work to do.
Yeah.
Period.
And it really does seem like the system is set up in such a way that you have to be sane and behave in an appropriate manner so that you can go get the treatment to be sane and act in an appropriate manner. You know, like this thing about, it's like, okay, you got 2 broken legs. Okay, we will put casts on you as soon as you walk around the block and come through our front door.
Yeah.
You know, and that's
yeah.
Okay, well, what else do we got? Are we done?
Yeah, I think that we have done it a good service. It's been a great chat. It's great to meet you, Angie.
Yes, you too, Marie.
Okay, thank you very much, ladies. I will let you get back to your evenings. Angie, I understand it's kind of late where you're at. It's about 11 o'clock over there, isn't it?
Yeah.
Yes, it is.
From one end of the country to the other.
Okay, so it should be said that Marie is in BC, I am in Saskatchewan, and Angie's in Ontario right now. So we've got a nationwide conversation happening here, and I think that's kind of cool. So we should have way more of them. So on that note, I will let you all go. Enjoy your evenings and take care.
Okay, thanks, Daniel. See y'all.
Good night.
Good night. Okay, let's see what we got here. Let us go to the call to action. Okay. Oh, I lost it. So, fostering change is our primary purpose here at Hard Knox Talks. If you would like to contribute to ending the stigma around emotional pain, please subscribe to our YouTube channel. Follow us on LinkedIn, Facebook, and Instagram. Like and comment your thoughts on our posts. Let us come together with our lived and living experience as a resource that has the power to engage new thought processes, to promote new ideas and broaden the spectrum of care, to show the world that there is a safer and more meaningful way to live, and we can show you how. Good night. That's the wrong one. There we go.